here. We're fortunate to have two great speakers with us today. I'd first like to welcome Dr. Avram Denburg. He is an oncologist with the Hospital for Sick Children, and his research focuses on the political, ethical, and economic dimensions of child health policy in both local and global contexts. His doctoral research examines normative and methodological issues in the assessment of child health technologies with specific focus on pharmaceutical policy and drug coverage decisions for children. Dr. Sumit Gupta is a pediatric oncologist in the Division of Hematology Oncology at the Hospital for Sick Children. His main research goal is to identify and improve the outcomes of vulnerable subpopulations of children with cancer. Lastly, I'd also like to introduce Dr. Mike Wilson, the Assistant Director of the McMaster Health Forum. He leads the forum's rapid response program and is conducting an evaluation to determine its impact on supporting the use of research evidence by health system decision makers. Mike's research is focused on supporting the use of research evidence by health system decision makers, including policymakers and stakeholders such as community-based organizations. Welcome, everyone. Abby and Sumit will start the discussion by providing an overview of childhood cancer care in low and middle income countries. Then they will share their top 10 insights on advancing the development of national childhood cancer care strategies in Latin America. They will then provide an update on some recent developments before we open the webinar to some discussion and questions and answers. But now, please welcome Avi and Sumit.
Great. Good afternoon, everyone. So this is a little bit of a new medium for me, so we'll see how we go. But Avi and I would both like to keep this relatively informal, especially since we have a limited number of participants, which is totally fine. But if there are any questions during the presentation, please feel free to sort of type them in that chat box. Otherwise, we have hopefully a decent amount of time at the end for further discussion. So I'll be taking the first half of the presentation, and then Avi will jump in and do the second half. So I think the first question that most people would ask is, childhood cancer in low middle income countries isn't an intuitive fit for most people. And so whenever Avi and I talk about this work with audiences who aren't familiar with it, the usual unspoken question is, why should we care about this? And we always answer in a couple of ways, but I'll give you a couple of the reasons first. So one is that, if you're talking about childhood cancer, the vast majority of children with cancer, Steve, I think we might have a formatting issue here. There's a few graphs here that aren't showing up.
Yes, sorry. When I tested that before, they showed up totally fine, but they don't seem to now. I will try and see about resharing this, and then maybe you can just continue on while I do that.
So,
second.
Yeah, no problem. So, one of the first facts is that if you're talking about childhood cancer, the vast majority of children with cancer do not live in countries like Canada or the United States or Western Europe. They live in low middle income countries. In fact, the percentage is probably about 80 or 85% of the global burden of childhood cancer falls in low and middle income countries. So that's one reason, but I think the even bigger reason is the percentage of childhood deaths that are actually attributable to cancer. So one thing to keep in mind is that in high-income countries like Canada, childhood cancer is the most common cause of disease-related death in children. So it's your number one disease killer of kids in Canada, the US, Western Europe. Now, in low-income countries, it's a far smaller percentage, probably around 3.5% by our best estimates. But as countries move up that development chain, the first thing that they make strides against in terms of childhood mortality are all of the infectious causes of mortality that, we hear about and see commercials about. Things like malnutrition, things like diarrheal illness, and childhood pneumonia or other respiratory illnesses. And as strides against those infectious diseases are made, the percentage of childhood mortality that's attributable to childhood cancer starts increasing and increasing. So, like I said, in low-income countries, it's probably only about 3.5%. But when you move to low middle income countries, you're now talking of about, sorry, I'm just pulling up my own statistics here. You're talking about 8% or 9%. And when you're talking about upper middle income countries, you're now talking about the neighborhood of about 18 to 20%. That's a really large chunk of childhood mortality, especially when you think that upper middle income countries, oh, there we go, perfect. Can I take over here, Steve?
You should be totally fine to take over. Thanks.
Awesome, thanks for fixing that. So for upper middle income countries, as I said, it's about 18 to 20%. And remember, upper middle income countries now include countries like Brazil, China, Indonesia, other such countries that are really accounting for a huge number of children. So we're really getting to the point in various countries' development that any further advances in childhood mortality really need to take into account childhood cancer. Now, unfortunately, even though low middle income countries are where most of these kids live, the outcomes in those settings is really quite inferior. So many people are surprised to learn that in high income countries, childhood cancer survival right now is about 80% if you look at all children with cancer in Canada as a group. In low middle income countries, it's far inferior, anywhere from 10 to 60%, depending on which country or what jurisdiction you're looking at. So there's this huge survival gap where your chances of surviving your cancer depend massively on where you happen to be diagnosed. Now, there are multiple reasons for that we're not actually going to go into in today's talk, such as increased or more delays in presentation, leading to advanced stages of cancer at presentation, things like toxicity being higher, but for all of those multifactorially contribute to this survival gap. So the dominant model for how people have to date addressed childhood cancer in low middle income countries is this concept that people have called twinning. And twinning is really a bidirectional exchange between a high income country center and a low or middle income country center, where resources and knowledge flow back and forth to try to improve outcomes in that low middle income country center. And on this map, there's just a few anecdotal examples of various twinning relationships shown. So for example, there are since this map was created, there's been a new twinning effort between our hospital here at Sick Kids in Toronto and various Caribbean pediatric oncology centers across the English-speaking Caribbean. So that model has done some really incredible, had some really incredible successes in terms of increasing the outcomes of children with cancer in participating centers. But this model is inherently limited. And to illustrate that limitation, I usually just draw people's attention to this one arrow that you can see Indonesia sort of lit up in orange there, with the arrow going from Indonesia to Amsterdam. And that represents a twinning arrangement between the VU University in the Netherlands and a childhood cancer center in Yogyakarta. And that relationship has done amazing things. It's increased the outcome for children with acute lymphoblastic leukemia, the most common childhood cancer, from about 30% to about 60 to 65% in only about a decade or so. So really impressive stuff. The problem, though, is to color Indonesia orange because of that one twinning relationship is totally disingenuous. Because the fact of the matter is there are probably another 1 to 200 centers in Indonesia that could use or benefit from the same type of help. And there are simply not 100 or 200 high-income country centers willing to start partnerships with those centers to be able to spread that benefit and spread those increases in outcomes to the rest of the country. So to do that, you really need to move beyond this twinning model and to talk more about population-based interventions. And when we talk about population-based interventions, we're really talking about national childhood cancer strategies, almost always needing government assistance or government buy-in. So that was the context for which we basically started the idea of having a brochure, having a foundation dialogue on this topic. So with the support of a grant from a NGO called the Brochet Foundation, located in Geneva in Switzerland, we convened a meeting of stakeholders looking at the advancing the development rather of national childhood cancer care strategies in Latin America. And we chose Latin America because a global focus just seemed too broad to get any specific messages out of, and also because Latin America, if you think about it on that chain of development from low to low middle to upper middle countries, are actually quite advanced on that chain. And so again, childhood cancer, while relevant, we would argue, in almost every settings, are especially relevant in Latin American settings. So we were fortunate enough to be able to bring together stakeholders from a variety of Latin American countries, as well as stakeholders representing clinical spheres, data management spheres, and governmental and policymaking spheres as well. So just as a quick plug, we're going to go into some of the different messages that came out of this, and Avi at the end is also going to talk about some of the steps that have happened since then. But one thing to bring people's attention to is a paper that basically summarized the proceedings and the results of the dialogue that was just published in the Journal of Cancer Policy, and the reference is here for you if you are interested to go look that up. So the format we were told to try to stick to was top 10 insights. So we've done this top 10 list style. So I'll take the first 5 and then I'll pass it off to Avi, who will take the next one. So the first 2 are the very, very obvious ones, but bear highlighting nonetheless. So even though I referenced sort of trying to restrict things to Latin America to try to narrow the focus, of course, Latin America is not a country, and there are a variety of settings and contexts across Latin America, and indeed within Latin American countries as well. And those settings and conceptual differences may impact what we're talking about in terms of childhood cancer policy a little bit or a lot. And then the second related message that came out strong and clear, again, to no one's surprise whatsoever, was that, of course, large inequities in access to healthcare in general, but specifically childhood cancer care, exist both within and across countries. And so many stakeholders made the point that any strategies, first of all, had to be flexible enough to take into account these different contextual realities, but also really needed to have access as a major focus as well. The third key message that came out was that data poverty was and is a major barrier to strengthening cancer care, and specifically childhood cancer care. And that data poverty we specifically left kind of broad because it applies to a couple of specific things. Some stakeholders talked about the lack of cancer registry data. So in a setting like Ontario, and in many if not all Canadian jurisdictions, and most high-income country jurisdictions, there are these population-based cancer registries, so that it is very easy to know what the burden of any type of cancer, including childhood cancer, is in your population. Not only a burden in terms of incidence, but also in terms of mortality and survival. And that allows policymakers to react accordingly. That data does not exist for the vast majority of jurisdictions in Latin America. There are some really great registries that have started and are doing a really amazing job, but they are the exception as opposed to the rule. Similarly, in a kind of an analogous way, there's also data poverty on both what type of national childhood cancer activities, right from the clinical level to the policy and healthcare system level, are currently in place across Latin America, what the differences between those are, and also what impact those have had on actual childhood cancer outcomes. And so again, that paucity of that type of data really makes it quite difficult to convince policymakers that this is a priority, but then even if those policymakers are so convinced, to tell them what they actually need to do in order to improve childhood cancers. What are the main factors in a childhood cancer policy that lead to success? How does that depend on the context? How much does that cost? And so the next two messages very quickly came from that overall theme of data poverty. Um, not It's quite easy to go from what I just said to say health policy and economics research has a key role to play in this field, again, to answer some of those questions for which answers do not currently exist. And then, as I referenced, message 5, that we really needed advocacy to dispel those myths around childhood cancer that many people have and to engage policymakers. But again, bringing these messages all together, stakeholders told us loud and clear that really that advocacy was very much dependent on having the data to support those advocacy messages. So with that, I will pass it off to Avi, who will take the next 5 messages and then talk a little bit about some of the exciting stuff that has happened since the dialogue took place.
Thanks so much, Sumit. And thanks, Stephen, for shepherding us through this, and to Mike for the invitation and the Health Forum generally. So I think Sumit's done a really beautiful job of setting up for all of you why. Can you hear me?
Yeah, I can hear you, Avi. You just muted yourself for a minute there.
I'm just having a bit of difficulty moving the slides forward. Up. Is that you or me?
That was me. There's arrows in the bottom left-hand corner you can use, or I can do it for you if
Okay.
that's still not working for you.
Oh, that's great. I see them now. Sorry about that. So yeah, Sumit's done a great job of setting up for you sort of the process we went through to begin to generate some evidence on how to deal with childhood cancers in low and middle income country settings in a more coherent and comprehensive way. And the first 5 insights he described really lead into this 6th one, which is that systems level practices and policies are needed. So we know from the slides Sumit showed you on twinning and his description of them, and we know from insights from our participants at this meeting that really these ad hoc strategies for dealing with childhood cancers in LMIC settings, and frankly in HIC settings as well, are insufficient. They've done great things, but if they're to be scaled up to regions of countries that don't have tertiary academic centers that are partnered in twinning relationships at them, if they're to engage other facets of the health system, then they really need to be national in scope. So, this is something we heard loud and clear, and some of the sub-elements of this insight came out through the dialogue as well, which are that we really need better knowledge of the elements of these strategies, how they vary across countries, how participants from different health system contexts have found different approaches to doing the same thing. And in particular, there was a lot of support for the notion that we need to rigorously evaluate these strategies, both from the point of view of economics and from the point of view of political salience and acceptability in a given health system context. There was also a lot of interest in understanding why across different Caribbean and in the context of this particular dialogue, Latin American countries, some countries have instituted national childhood cancer strategies or variations thereof, and others have not. And I'd say that's a wider question for the field globally. So something else that came through loud and clear, though, is that just because there's need for systems levels, practices, and policies doesn't mean that there's a one-size-fits-all solution. So our 7th insight is really that there's more than one way to skin a cat. And here we put up 2 very disparate examples, Guatemala and Chile, of how countries in Latin America have approached health system strengthening for children with cancer in very different ways, with somewhat different results, but in both cases, pretty excellent results that have achieved arguably something close to national scope. So Chile is an exemplar in Latin America and arguably globally in the treatment of children with cancer and in a national approach to it. They really, over the course of the last 3 decades, have worked in tandem with government. These are pediatric oncologists and childhood cancer professionals, have worked in tandem with government to build up a system that's national in scope with respect to its referral capacity, that's financed nationally, based on levies from tax-funded funds from government, where money follows the individual patient from the point of initial contact with the healthcare system and initial diagnosis all the way through referral to a tertiary care center, to treatment at that center, and to some elements of survivorship care. And that's contrasted with Guatemala, where really it's taken the efforts of a small group of people, and in particular one very motivated and passionate individual who's a colleague and friend of ours, to build up the pediatric cancer program there. And he did it largely without the involvement or support, at least initially, of government. And the reason that that approach was chosen in that context was really because of perceptions around how effective government could be in that space, and of competing priorities in the health system that would preclude more sort of entrenched government involvement at the outset. So much of the financing for pediatric cancer care in Guatemala initially came from a private foundation that our colleague Dr. Antillon engaged, and through twinning partnership with St. Jude Cancer Center in Memphis in the States. And through those relationships, he was able, with his colleagues and supportive hospital environment, to build up a program that was initially institutionally based and privately financed by and large, to one that has now increasing reach throughout the country, and that has garnered increasing financial support from government based on that proof of principle. So two very different routes to similar outcomes for children with cancer in those contexts. So the remainder of our bullets really build off those last ones, and you can probably intuit some of them. So one thing, again, that Sumit and I face in many of these discussions around building up these systems of cancer care for kids in these countries is, aren't there opportunity costs to doing so, competing resource priorities, and what about strengthening the rest of the health system? How are we going to spend money on doing this with kids with cancer when there's a whole weak health system that needs strengthening in a given country context? And not to diminish the importance of that argument, we would argue, and have heard from our colleagues and participants to this dialogue, that really what they've noticed and what they hope for is that these improvements in childhood cancer care really work to strengthen the health system more broadly through a variety of mechanisms. And we've seen that play out. So childhood cancer is complex in its diagnosis and treatment, and really requires many facets of the healthcare system to work fluidly and in tandem in order to properly treat a child with cancer to good outcome. That involves everything from working and relatively well-oiled diagnostic and referral capacities up through tiers of the health system, from primary care to tertiary, working DI, diagnostic imaging, and pathology expertise at various levels of the health system in order to make the diagnosis accurately. As Sumit has alluded to, systems for data storage, repository, and evaluation that can extend well beyond childhood cancer. And the capacity to transition kids back from tertiary centers to secondary and primary tiers of care for follow-up. All of these things require better engagement at different levels of the health system, and there are opportunities to strengthen facets of the health system through improvements made to childhood cancer care. That's a concept many of you will know called diagonal health system strengthening, and it's been demonstrated in the context of other illnesses and domains like HIV, and tuberculosis care. So we feel that the same principles can and will apply to childhood cancer health system strengthening. We also noted, however, that there are some challenges that really sort of either belie or are very difficult to solve from the perspective of individual countries or jurisdictions, and that would really benefit from the combined muscle of a regional approach. And I'll get into some of those in a bit more detail. And finally, and this is probably intuitive and is the case for most successful and important interventions, we have found that people make all the difference in this context. So, I referenced our colleague in Guatemala who did really the bulk of work to make huge differences in his country context with respect to treating children with cancer. And our experiences has been that in all the Latin American countries we have worked in and are working in, as well as other countries, it really takes champions on the ground to make this issue a priority for policymakers in the country, make it one that is a living reality for providers on the ground, and to translate those energies and expertise into differences for the kids. I should note, it's a good opportunity to also note that collaborations both across HIC and LMIC settings and even within HIC settings have been instrumental in improving outcomes for kids with cancer in low and middle income countries. And Sumit and I are extremely grateful to the Health Forum for partnering in this dialogue. It brought their expertise in deliberative stakeholder engagement and translating evidence to policy to the table in trying to garner from participants across a broad array of Latin American countries what the challenges are that they're facing and how to solve them, and to see those nicely and package them impactfully. And also we had funding and support that was instrumental from the International Union for Cancer Control. So it really is these kind of cross-jurisdictional and global partnerships that can make the difference, and people are crucial to those. Those are our top 10 insights. I'm happy to pause if people have questions, but I'll actually keep going given the format, and do encourage everyone who's participating to put their questions or comments in at the bottom. We have a relatively small group, which is actually good for intimacy and for time for questions, so encourage that again. So I just wanted to précis some of the elements of solution that came out of the specific brochure dialogue on which this webinar is based, to give you a flavor of some of the actions participants prioritized and some of the progress that is made on those in the intervening months. The first thing that came through most clearly was the need for, as I mentioned earlier, a regional approach to certain problems. And in this regard, participants all felt that a pan-regional task force in Latin America on childhood cancer health system strengthening was crucial. They felt they learned a lot from each other in terms of the challenges faced and discussion of potential solutions there too. And they felt that they identified certain issues where regional priority setting and action plans would make a difference. So one example that I'll speak to in a little more detail subsequently, but will give you a flavor of this, is drug procurement and supply management to get the necessary drugs to kids in country across the region. All the participants to the meeting recognized that this was a challenge, that this was something that was very hard to do, even at the national level in their context, because of issues with economies of scale for buying medicines, fragmented markets that make it hard to project demand, purchasing power and voice across the regions being very disparate. So for all these reasons, they recognize that taking an approach together for drug buying and for supply management issues and learning across countries on this would be very valuable. This is something that has been a learning even in our context in Canada in terms of drug purchasing, and participants recognized comparably that this was an issue that needed regional scope there. Another big domain was health system guidance. So Sumit referenced the lack of high quality data in many of these country settings, and that extends beyond the epidemiologic data around cancer incidence and survival and mortality that might be contained in registries and might be strengthened by registry building to better health policy and health economics and health system data. So all the participants recognize that ultimately the development of some sort of knowledge hub and capacity for knowledge exchange and translation would be a key priority for them. And then finally, allied to that, that there should be better monitoring and evaluation of the epi itself. So high quality cancer registries and some indicators for common benchmarking therein. So just to give, again, a flavor of the way that participants articulated solutions to these challenges, just a couple of examples. I mentioned that early detection and referral of cancers is an issue that is a big one in pediatric cancer in terms of optimizing outcomes, and also a challenge for health systems in many low and middle income countries. Oftentimes integration of referral mechanisms is pretty poor, so that either a kid who comes to their primary care provider with symptoms of a cancer is not recognized to have a cancer, or if he or she is, there's not good knowledge about how to refer up through tiers of care to get them the care that they need. So participants identified a number of elements of a possible solution to this problem in those three main buckets I just talked about. So with respect to the Pan-Regional Task Force, they thought that this would be sort of a key node where core diagnostic capacities for referral centers could be identified, and parameters for optimal referral pathways identified as well, to give guidance to individual countries. Similarly, if there were knowledge translation materials developed to share programs on how to optimally do diagnosis and referral, that could be directed to the primary healthcare level. Again, participants felt that this was something of value that could benefit many countries in the region. And likewise, in the domain of monitoring and evaluation, having some mechanism to track and introduce accountability measures to reduce referral delays, and develop some common procedures and checklists across the region. Just to note, some countries are doing some elements of these things, other countries aren't, or are doing things in different ways. So again, this was a real positive exercise in understanding the opportunities across different settings and in learning from them. Chile has legislated and gives incentives for timely referral of pediatric cancer patients in the country, so that it actually incentivizes providers at the primary health care level and up tiers of care to refer kids in a timely way. And both Mexico and Paraguay, for instance, have wide public campaigns on early warning signs. I'll skip the rest of this as I spoke a bit to drug procurement and access, except to say that there are examples already of global and regional overlay to improving access to medicines for children that participants felt really could come into play in their jurisdictions. And one notable example is the PAHO, the Pan American Health Organization's strategic fund for bulk medicines procurement in the region that hasn't yet been leveraged well enough for pediatric cancers. I'm going to pause here just for one sec. There's a couple videos to show you, and hopefully Stephen will help get those up. I just want to note there are a couple questions. So Devin asks, thank you for the questions, by the way. Have either of us looked into issues really around quality of medications in LMICs? And are issues with either falsified or substandard medications a problem? That's a terrific question. The short answer is that yes, we are doing some work with colleagues on this front, and yes, there are issues with respect to the quality of cancer medicines for children. One notable example is asparaginase, which is a key medicine in the treatment of childhood leukemia. with some colleagues in the UK and in India, we've looked into quality of asparaginase issuing from a variety of providers in the Chinese and Indian contexts, and have disconcertingly noted that there's huge variability in the quality of the medicines produced. So careful attention needs to be given to where medicines are purchased from, and to have robust quality assurance mechanisms at the point of purchase or production in the medicines that are purchased. And I think Devin's question is an important one, because this has been an issue that has stymied efforts to purchase pediatric cancer medicines and cancer medicines more broadly in bulk in a regional or more global way, because there are concerns around the quality of the generic medicines produced. There's another question around expanding on the Chilean case study. I think maybe I'll let that question from Samia stand till the end, if that's okay, just so we have an opportunity to get through these videos and the rest of the presentation. Great. And then we can dive into things with a little more detail. So this is the Vice Minister of Health, who was party to our dialogue. Thanks, Stephen. There doesn't seem to be volume, but he's speaking in Spanish anyway. The next one is in English. So Stephen, if videos are going to work like this, we'll perhaps skip the next one. What I hope you can note, even though you can't hear him from the text underneath, is that he's really hitting on a lot of the themes that we've addressed.
Sure.
We can give this one a try and see, and if it doesn't work, then we'll skip it.
What has worked for them, what try to identify.
Okay, Stephen, maybe we'll skip it. What I wanted to illustrate with those videos, and thank you for that, Stephen, is really that just to give you a bit more of a sort of living sense of how participants responded to the dialogue, and how many of the themes that and insights that we've addressed today derive from that and sort of were articulated by the participants to the dialogue. To try to illustrate how powerful deliberative dialogues of this sort can be. So moving on, we wanted to update you on some recent developments. And we're excited about many of these. So I'm going to focus first again on this pan-regional task force, because we've made some real headway here. When we were having the dialogue, considerations that the participants thought would be most important for a task force for legitimacy and impact were that it have a coherent statement of purpose and clearly articulated values at its base, that it have strong governance, and importantly, I think that it focus specifically on activities that have or could benefit from pan-regional scope, recognizing, as most of the participants did, that their country contexts were unique and there weren't one-size-fit-all solutions. So with the key support of PAHO and again UICC, we convened a task force on this front that folded in both the participants to this initial brochure dialogue, as well as participants from a number of other Latin American countries, and in addition, a variety of the English-speaking Caribbean countries with which SickKids is already working, to establish a task force headed up at PAHO and with governance through PAHO to try to better deal with issues of pan-regional scope for all the countries involved. I should note that all these participants were Ministry of Health sponsored or identified delegates or participants, so they may not have worked directly within ministries, but they were key people in their countries that the ministries identified as crucial to this issue. So they're already, to a certain degree, empowered in that context. We had 12 countries, we had 20 countries represented at this meeting. And prior to this meeting and growing out of the Brochet Dialogue, what we undertook to try to better flesh out situations on the ground in the lead up to the development of this task force is a wide comparative policy analysis across the region that initially involved 12 countries in its first phase that is now wrapping up and will ultimately, we hope, involve all 20 countries represented in the region, including the Caribbean ones. So that has been really fruitful and instrumental in our understanding of systems and policies in the region that have bearing on pediatric cancer, and this work is continuing. So just to give you a sense of how participants conceived of the utility and role of this task force or working group. They saw it having a few major functions, only some of which are coming up. There you go. So firstly, they thought it was the opportunity to be the node or the nexus for this evidence hub that was described as a potential solution to some of the problems articulated in the dialogue. They also thought that the working group or task force could act as a key node for knowledge exchange with local stakeholders in a given country context on issues with respect to childhood cancer systems, and importantly, help local stakeholders with knowledge translation efforts to their decision makers in their country contexts. And finally, it could serve as a legitimate regional liaison on the issue of childhood cancer in Latin America and the Caribbean to various ministries of health. So that's the hoped for purpose of this task force. It's in its early stages, but already we're seeing some movement. Shifting gears a little bit, some of the other fruits of some of this work in the context of the dialogue has been, as I mentioned, to try to better understand and map childhood cancer systems or policies in various LMIC settings. And to do that, we really wanted to improve upon the theoretical foundations for doing this on childhood cancer specifically. So there are lots of frameworks or models for doing health systems analysis. There are some that we initially developed for this Latin American analysis that focus more on childhood cancer, but we wanted to take the opportunity to do this right going forward so that we make sure that when we are mapping policies to try to strengthen childhood cancer health systems, we're doing them in as evidence-based way as possible. So we undertook a consensus exercise that's still ongoing to develop a health system framework for understanding childhood cancer policies and systems globally. That could be in low, middle, or income or high-income country settings. This is still under development, but draws in classic and well-established frameworks for health policy analysis and health systems analysis with more childhood cancer-focused ones to create what we hope will be a resource and kind of a gold standard for doing health systems analysis in childhood cancer going forward. We've also undertaken some additional empirical work, some of it in the Latin American context, to try to understand the different systems and policy trajectories of certain countries that stand out, that are doing this in an excellent way, to serve as learning case studies for other systems that are trying to improve cancer care for kids. And Guatemala and El Salvador are two of those countries that are doing really excellent jobs at delivering institutionally based childhood cancer care that also have managed to integrate and diffuse some of their capacities and systems to the rest of the health system. And that work is ongoing as well. So I think I'll stop there and leave a good 15 minutes for discussion and questions. Both Sumit and I are really grateful for this opportunity and really curious to know how this has struck you and what questions you have. If the issue of childhood cancer resonates as an issue in need of dealing with in low and middle income country contexts, and we may have some selection bias there based on who's joined the call.
Thanks very much, Avi and Sumit. That was a very excellent presentation. As you mentioned before, if anybody has any questions, please use the chat box in the bottom right-hand corner to ask those. In the meantime, Mike, I think you're online, but if you have anything to add in terms of discussion or anything, or Sumit, if there's anything else you want to add to comment on what Avi was mentioning.
No, I don't have anything extra to add. If we want, we can start with going back to Samia's question as well.
Yeah, sure. Why don't we do that? And in addition to questions and answers, just going with this sort of topic here, if there was any of those top 10 top 10 highlights that particularly resonated with anybody, that would be interesting to share as well.
Great. So, no, go ahead.
So, Samia, oh, go ahead.
Sure,
Samia.
if you want, I can take a bit of a crack at that one, and then obviously anything you want to add, feel free. So Chile's a really, really fascinating example. First of all, just from the outcomes that they have achieved. So, if you look at childhood cancer outcomes in Canada, to date, we'd probably quote an overall survival cure rate of about 80% or so. And Chile's at about 70 to 75%. So really, really close to the best outcomes you would find anywhere in the world. And the way that that was accomplished was through a very deliberate network of treatment centers with buy-in from the government, to cover various treatments, and a really fascinating sort of well thought out system with centralization of care as well. I'm always interested in how Chile has done some stuff that almost no high income country system has done, which is say, if you need surgery for osteosarcoma, bone cancer, that's a very complex thing. So this is the center in Chile that does that for all Chilean children with osteosarcoma. If you need a bone marrow transplant, this is the center. So there's been a lot of thought into it. Now, the question that we're all really interested in is how did that come about, and what was different about Chile that allowed that to come about? One of the interesting parallels is that Mexico, a small number of years back, tried to institute a similar policy modeled very deliberately on what Chile had done. And the very initial data that's coming out seems to suggest that it may not be having nearly as much of an effect as the Chilean system did. So I think there's a bunch of questions there. Why did it come about? Why did it seem to work much better in Chile than it is in Mexico? And there are various suggestions there that people have put forward. That was a topic of conversation in the PAHO meeting that Avi was referencing. But there's a lot to learn there, and in fact, we're partnering with some some folks and some collaborations in both Chile and in Mexico to more formally study that. Avi, did you want to add anything to that?
No, I think that's terrific, Sumit. Yeah, I think Simia's question's fantastic, and the short answer, as Sumit has alluded to, is we don't know yet, and so we're going to try to do some work on this with some partners in Chile and Mexico. The other thing that our colleague is always careful to stress, our colleague from Chile, who's been instrumental in these discussions, and been sort of a node in her country for putting information in our analysis efforts, is that it's taken them many, many, many years. So this has been grunt work on the part of people passionate about the issue. To our people are important bullet over the course of 3+ decades. And it needs further study as to why exactly government took this on as an issue and improved the health system in that regard. So it's a fantastic question. And we need people interested in doing this. So Samia, if you're interested, we should keep talking.
Excellent. Well, thank you very much, Avi and Sumit. Those were excellent answers, and certainly a very interesting presentation on a very important topic.